Good morning and good afternoon. I'm Charles Flexner from Johns Hopkins University, and I'm going to be talking for the next 20 minutes about novel formulations and devices in development for treatment and prevention of HIV. Here are my disclosures as required by the organizers. I'm going to talk mainly about antiretroviral implants and antiretroviral microarray patches, that is transdermal antiretroviral therapy. You've heard already from Dr. Bofito about the use of intramuscular injectable long-acting antiretrovirals, and I want to shift gears and think about other possible ways to deliver antiretroviral drugs. Specifically, first we'll talk about implants, and I'd like to address this question: why even consider implants in the place of long-acting injectable ARVs? Well, long-acting antiretroviral implants do have some potential advantages over injectables. They are removable, particularly in the inert, non-erodible forms or in the early stages of erodible forms, as we'll discuss shortly. They provide more consistent and predictable drug release. Their pharmacokinetics are not dependent on the injection site, as may be the case with intramuscular injections, and they can remain in place for years. In the case of contraceptive implants, for up to 5 years after a single implantation for the inert, non-degradable subcutaneous versions. They do, however, have some potential disadvantages over injectables. They require a specialized device for insertion and a minor surgical procedure to remove them. They should be removed if they're not bioerodable, because simply palpating the device does not tell you how old it is or how long it has been in place and whether or not it's still releasing drug. These devices are regulated both as drugs and devices by regulatory agencies like the FDA and the EMA, which complicates their regulation, but may also make it more difficult to move them to a generic marketplace for low and middle income countries. The greatest experience with implantable devices for drug release is in long-acting implantable hormonal contraception. Over 40 million women worldwide use injectable contraception, and nearly half of modern contraception users in sub-Saharan Africa rely on injectable or implantable contraceptives to prevent pregnancy. Women report that returning to a healthcare provider for an injection every 2 to 3 months is a disadvantage of DMPA, the most commonly used injectable contraceptive. And discontinuation rates of injectable contraceptives are therefore high, contributing to the growing popularity of long-acting implants. Levonorgestrel implants, which are available in several generic forms, are now used by millions of women in sub-Saharan Africa, and they are manufactured and administered quite inexpensively. The cost for a generic levonorgestrel implant in sub-Saharan Africa is now less than $15 US, or about $3 per patient per year for effective hormonal contraception, making this approach quite cost-effective. The implant quandary, however, is whether to develop your drug delivery in an inert, non-erodible form or in a bioerodable form. So what is a bioerodable implant? This is a drug delivery procedure that many of us are unfamiliar with in the anti-infective field. Here are some figures from Eric Apple at Stanford University showing one example of a bioerodable implant. In this case, a polymer nanoparticle hydrogel. The polymer is mixed in a syringe right before injection, and when the polymer is injected, it forms a semi-solid glob that absorbs water and is slowly degraded over time. And that's shown in this figure. This kind of hydrogel can be used to greatly extend the apparent half-life of delivery of candidate drugs. In this case, a monoclonal antibody. Shown in the black figures over here is the relatively rapid clearance from the blood of this monoclonal antibody in mice. as compared to the very extended and slow release of this monoclonal antibody when delivered as a nanoparticle hydrogel. One of the great advantages of bioerodable implants is they do not have to be surgically removed unless the recipient has a significant adverse drug reaction, which would allow the hydrogel to be removed soon after injection and before it starts to erode. What can we learn about the value of bioerodable implants from their use in other disease areas? Well, it turns out that tens of thousands of people have received bioerodable implants for the delivery of therapeutic hormones. The most popular of these is leuprolide acetate, or Lupron, often used for the control of prostate cancer. This is a gonadotropin-releasing hormone receptor agonist. These GnRH agonists are small peptides that are widely used for the treatment of prostate cancer, breast cancer, endometriosis, and central precocious puberty. Bioerodable implants have been used to deliver leuprolide, goserelin, as well as non-erodable implants for the delivery of another GnRH agonist, hysterelin. They consist of the drug co-formulated with a biologically inert polymer, usually a polylactide glycolide, PLGH or PLG. The implant system may be preformed and injected subcutaneously, as was shown in the example from Eric Apple, or they may be administered after they harden as a small rod. The implant then dissolves over a period of 1 to 12 months, releasing drug as it erodes. The safety and tolerability of these implant systems in humans is generally excellent, suggesting that they may hold promise for the delivery of drugs for HIV and other infectious diseases. This is an example of the pharmacokinetic profile of one of these GnRH agonists, hysterelin or suprelin, showing its very gradual release from the implant over a period of 12 months. The different lines represent different kinds of patients, but they all have roughly the same pharmacokinetic profile. I want to turn now to non-erodable implants being developed for treatment and prevention of HIV and talk specifically about Etravirine, which is being developed by Merck. Etravirine has been looked at in a variety of implant candidates. And here is a figure from a paper published by Stephanie Barrett and her colleagues 2 years ago, looking at 3 different implants designed for slow release of Etravirine over time. These are data from rats showing the concentration time profile in the plasma of Etravirine or MK8591 over a period of up to 600 days. The 2 implants on the left in A and B are actually bioerodable implants, but the implant on the right in C is a non-erodable implant based on the polymer EVA. All 3 of these implants can release effective concentrations of Etravirine for greater than 180 days after a single implant. And modeling data suggests the potential to provide coverage in humans for a duration of up to a year with one of these implants. In fact, there is now proof of concept in humans for a non-erodable Etravirine implant. These are data that were presented last year at the IAS meeting by Randy Matthews from Merck, showing the concentration time profiles of 2 different solid-state non-erodable Etravirine implants in healthy human volunteers. And what we can see is that both of these implants maintain average concentrations over the target for the entire 12-week duration of the implantation. And after the implant is removed, the islatravir is cleared from the system, in this case, measured by the intracellular islatravir triphosphate, the active metabolite, at a rate that is similar to that of orally administered islatravir, suggesting that there is no prolonged reservoir of islatravir after the implant is removed. This implant with 62 milligrams of islatravir delivers much higher concentrations in the studied individuals, and this implant is being further studied in phase 1B and phase 2 as a possible preventive agent or PrEP agent for HIV, and may eventually be combined with other agents for treatment. This is what the islatravir solid-state non-erodible implant looks like. It's based on the same technology used for the Nexplanon or etonogestrel contraceptive implant that is also made by Merck and uses the same applicator for insertion into humans. I want to, however, insert a note of caution about implants, both erodible and non-erodible implants. And this relates to the fact that not every drug may be suitable for implantation, and not every implant formulation may be suitable for long-term administration in humans. This is a study that was published by the group from Merck, who were interested in developing a long-acting implant of their hepatitis B drug, Entecavir. And in a paper published in 2019, they found that this Entecavir implant actually resulted in local inflammation and tissue necrosis in animals, probably as a consequence of an immune reaction to the way the drug was being released over time in tissues, probably not a reaction to the components of the implant itself, which are thought to be biologically inert. But this suggests that we need to be careful about implant development and make sure the implants we are developing are safe in animal models before taking them into humans. Similar reactions have been reported with some candidate tenofovir implants, and so this is not something confined to Entecavir. I'm going to switch now, and in the last half of my talk, I'm going to discuss transdermal drug delivery using microneedle array patches. Why consider transdermal drug delivery instead of injection or implantation? Well, transdermal patches have potential advantages over injectables or some implantables. They can, of course, be removed after the patch is applied. They can be applied by the patient or by a family member and don't require coming to the clinic. Pharmacokinetics may not be dependable on the site of placement, although that requires greater study, but patches can remain in place for days or weeks, as we have learned with patches used for hormone replacement or nicotine addiction cessation. They are also appropriate, unlike implants and injections, for short-term drug delivery, for example, once a day or once a week. And that has real advantages in settings like infants and newborns who have difficulty taking oral antiretroviral medication. But as compared to implants or injectables, microarray patches have some potential disadvantages. There are a limited number of drug candidates that are sufficiently potent to allow formulation in a microarray patch. They have a complex manufacturing process. They are expensive to manufacture, therefore, Like implants, they have a complicated regulatory environment, being regulated as both a drug and a device, and there may be difficulty moving them to a generic marketplace for low and middle income countries. One makes a microarray patch by loading the nanoformulated drug at high concentration into aqueous gels that are then cast into a mold. After they dry, you apply a border adhesive and an occlusive backing layer to form the actual transdermal microarray device. This base plate needs to readily detach once these microarrays, or so-called microneedles, dissolve in the skin. In addition to formulation with unmodified drug, you can also use nanoformulated drug in these microarray patches. And with nanoformulated drug, once they are deposited subcutaneously, they form a nanoformulated depot to release drugs slowly over time for absorption by the rich dermal microcirculation. And I'll show you some examples of that shortly. This is a figure from Ryan Donnelly's group at Queen's University in Belfast with a cartoon showing how a microneedle or microarray patch is made. And this is a photomicrograph of the final microneedle, in this case formulated with a single drug, but you could also formulate microneedles with multiple drugs. In addition, as I said earlier, you can take nanoparticles, as shown here, to create a microneedle that is essentially a Christmas tree of nanoparticles. And once these microneedles are inserted under the skin, they form a subdermal reservoir for gradual drug release, similar to the strategy achieved with intramuscular injection of long-acting cabotegravir or rilpivirine. In fact, this is what Etravirine microarray patch looks like in terms of pharmacokinetic profile in an animal model. These are, again, data from Ryan Donnelly's group that he graciously shared with me, looking at the pharmacokinetic profile of an Etravirine microarray patch in animals in the red line and the green line as compared to intravenous Etravirine at 2.5 milligrams per kilogram. And as compared to the intravenous Etravirine, which still has a fairly long half-life, the microarray patch in these animals produces very gradual release of this drug, whether given as the unmodified drug or as the nanoformulated drug in the green, which produces a higher trough concentration. And this is over a period of nearly a month. Similarly, for cabotegravir microneedles or a cabotegravir microarray patch in an animal model produces very good controlled release over time of cabotegravir in the plasma. In the blue line here is cabotegravir, the formulation we're familiar with, Cabotegravir LA, given intramuscularly to these same animals at a dose of 2.5 milligrams per rat. In the red line is a nanoformulated cabotegravir microneedle, and in the green line is a straightforward cabotegravir formulation. And what you can see is that you get higher initial concentrations with the nanoformulated cabotegravir, but at the end of a month, the concentrations are quite similar. However, all three formulations achieve concentrations of cabotegravir that are far higher than the target, which in this case is 4 times the protein-adjusted IC90. It's important to point out that the cabotegravir microarray patches require nearly 5 times the dose to achieve concentrations that are about half or less what one would achieve with the long-acting cabotegravir injection. And so in this particular model, if we want to achieve concentrations that are similar to or identical to Cabotegravir intramuscular injection, it looks like we still have some work to do. We have done modeling in collaboration with colleagues at the University of Liverpool to look at concentrations of Cabotegravir after applying a modeled 30 to 60 centimeter square microarray patch in adult humans. These are data that were published last year in the Journal of Infectious Diseases. And what you can see is that depending upon the mass dose of the microarray patch and depending upon the release rate that the patch achieves, concentrations of Cabotegravir may be released over a 28-day period after an application of a single patch that maintained concentrations above the target, which in this case is the trough concentration achieved in humans after taking a 25 milligram oral dose. What does it feel like to wear a microneedle patch? Well, this is a human volunteer, in this case me, wearing a candidate microneedle patch. In this case, a patch containing placebo, at least I was told it contained placebo, provided by colleagues at a company in Singapore that makes microarray patches for clinical use. I put this patch on in the morning thinking it would bother me, but in fact, after application, I walked around all day with this patch on my hand and removed it at the end of the day. And what I saw was nothing but normal skin. Applying this patch feels a little bit like taping a piece of sandpaper to your hand. It doesn't hurt. And removing it, I could not even tell where the patch was. These microneedles are like 1,000 mosquito bites with no itch. And so I think this is a technology that has great promise for antiretroviral drug delivery, particularly in people who have trouble with pills or injections, and especially in populations like infants and children. Ryan Donnelly's group has been working with an engineering company to create a microneedle patch that turns color when it is appropriately applied to the skin. And so in this example, when appropriate contact pressure is applied to the patch, the exterior of the patch, the external surface, turns red. So the patient or the person applying the patch knows that it has been properly applied. 3/4 of the human volunteers who received such a patch preferred it over the microneedle patch without this red censored indicator. So that is the end of today's presentation. I want to thank my collaborators who provided me with much of this data, particularly collaborators at Johns Hopkins University, Stanford University, the University of Liverpool, and especially Ryan Donnelly at Queen's University in Belfast, who shared with me this unpublished data on a variety of antiretroviral microarray patches used in animal models. This was from a presentation he gave at the annual LEAP workshop in March of this year. I also want to acknowledge the funding sources who support my work in long-acting device development, and particularly the long-acting extended release antiretroviral research resource program, LEAP, and you can learn more about us at this website. Now, we would be happy to answer questions from the audience and look forward to hearing from you. Thanks.